Welcome to LifeLab Conversations. GLP-1 medicines have transformed the treatment of obesity, but they should no longer be thought of simply as weight loss drugs. They are cardiometabolic medicines with benefits that extend well beyond the number on the scale, including reductions in cardiovascular risk, prevention or delay of diabetes, and a meaningful effect on diseases such as fatty liver disease. Access is also beginning to improve. Through the new Medicare GLP-1 Bridge program, eligible Medicare patients can now receive certain weight loss medicines for a $50 a month copay. And the field is moving very quickly. Newer drugs are in late-stage development, including retatrutide, which targets GLP-1, GIP, and glucagon receptors and may offer even greater weight loss and broader metabolic benefits if approved. Today, I want to move beyond the hype and ask the clinical questions that matter. Who should receive these medicines? What are their real benefits and risks? How should they be used over the long term, and what is coming next? To help us answer those questions, I am joined by Dr. Nisha Patel. Dr. Nisha Patel is a board-certified internal medicine physician specializing in obesity medicine, cardiometabolic health, and culinary medicine. She serves as the medical director of the Obesity and Metabolic Health Program at California Pacific Medical Center, where she leads an interdisciplinary team focused on improving access to life-saving therapies for patients with obesity, complex chronic diseases, including those awaiting or recovering from organ transplantation. Dr. Patel's work bridges clinical medicine, nutrition, and public health, with a particular interest in translating evidence-based nutrition into practical, culturally relevant strategies that patients can realistically incorporate into their daily lives. She is passionate about reducing barriers to healthy eating, combating nutrition misinformation, and helping clinicians use food as a powerful tool to prevent and treat chronic disease. In addition to her clinical leadership, Dr. Patel is an educator, a speaker, and a writer who is committed to making medical science accessible to the public. Her work explores the intersection of women's health, nutrition, obesity, motherhood, and health equity, with an emphasis on reducing cognitive overload and empowering people with practical, evidence-based guidance. As a member of the advisory board for the American College of Culinary Medicine, something I am definitely going to ask her about, Dr. Patel is excited to help advance the integration of culinary medicine into medical education and clinical practice while promoting innovative approaches to improving population health through food. Nisha, welcome to LifeLab Conversations.
Thanks so much for having me.
Yeah, I'm very excited for this conversation. You really are an expert in a number of areas that are going to be fascinating for our viewers to hear about.
Yes, I am so excited to start diving in and talking about all of these wonderful areas. Yeah.
All right, let's do it. So my first question, how do you decide who's an appropriate candidate for a GLP-1 or related weight loss medicine?
Yeah, great question. It really starts with that initial medical consultation where I get to know my patient. They're coming to me the very first time. Perhaps they've tried different therapies or they've seen other providers or tried different programs. And I really want to understand that history. Like, what has their journey been like? If it's regarding weight management, we talk about that history dating all the way back sometimes to childhood when, some of our patients have struggled with their weight since childhood. And we really want to understand what their medical conditions that they have. We want to understand what medications they're taking. I mean, that medical assessment is so crucial, right? Mm-hmm. We don't want to just promise patients like, hey, these medications are for everyone. Here they are. See you later. That's really not the right thing to do for people. And after we have that discussion, we really sit down and look at their medical history and think about, okay, which one of the therapies out there is going to be the best option for you. We have multiple now, right? We have injectable medications when it comes to GLP-1s, and we also have pill GLP-1 medications. We also have non-GLP-1 weight management medications that I still use on a regular basis, sometimes, as a solo medication, sometimes in addition to a GLP-1 medication. And so all of these considerations have to be taken into account when we're thinking about it. Now, the FDA has criteria that they list for who is a candidate for GLP-1 medications. Patients with, and unfortunately, it's a lot of it's BMI based, which again, it's not encompassing of really truly understanding somebody's cardiometabolic risk, but it is what it is. And so patients that have a BMI of 27 with a obesity related comorbidity like sleep apnea, for example, are a candidate, and then anyone with a BMI of 30 or greater, regardless of whether or not they have that comorbidity. Now, I will say the Bridge program has its own criteria, and a lot of the insurance companies, unfortunately, they don't really always follow FDA criteria. They have their own criteria, and so it just really depends on, what's this medical background? Do they have coverage for medication? If so, what does that look like? If they don't, can they afford paying out of pocket? I mean, all of these things have to be taken into account when we decide who is ultimately a candidate for GLP-1. And is there a risk of harm, right? I don't want to harm a patient. Nobody does. And so we really do want to make sure we have those thoughtful conversations about, risk versus benefits. And I will say in the majority of patients, their benefits far outweigh potential risk.
Great. So do you think that the insurance coverage has improved with both the Bridge program and with other insurance companies shifting guidelines around approval of either GLP-1 medicines or some of the other medicines that you use?
Yeah, I think in certain situations there is improvement, and then in certain situations, unfortunately, we've gone backwards. For example, patients that were on Medi-Cal in California lost coverage for strictly weight management, and that was really devastating to them because, they're often not the patients that can pay out of pocket. And so I'm hoping at some point that type of coverage gets reinstated, especially now that there's the Medicare Bridge program. As far as insurance companies, there's a lot of scrutiny about what's the medical indication for this medication? I think insurance companies don't love covering it for weight management alone. They often want to cover it for, sleep apnea, along what was formerly known as fatty liver disease. Diabetes, of course, has always had a pretty universal coverage. The difficult part of this all is there's just a lot of administrative red tape to get these medications covered for patients, especially when we're going through the insurance route, as you know. And it can be really challenging. I mean, I can't tell you how many times I have fought with insurance companies, gone back and forth, because these patients really would benefit from this medication class. And it's just, it's hard. It's hard. It's disheartening for patients. It's disheartening for doctors and providers. So, yeah, it's a little bit of a nuanced answer. In some ways, it's gotten better. In some ways, it's gotten worse.
Mm-hmm. You mentioned risk benefit ratio, and I want to use your expertise to understand that a little bit more for our viewers. And so can you talk a little bit about that, the risk assessment that you do for a patient, and then how you incorporate that information into a risk benefit ratio for the patient in front of you?
Yeah. So I see a patient population that's a little bit different probably from not every weight management clinic. I'm sure there's overlap, but my patients are what I generally call sicker. They have multiple medical conditions. Some of them have, end stage disease, meaning they're on dialysis because their kidneys have failed, or they have cirrhosis. And so this is a population of patients that has not traditionally been included in clinical trials. If you look at the clinical trials, technically they are healthier individuals. Yes, they might have comorbidities. And I'm not saying that's true to every single clinical trial, but a lot of them don't include all these patients. So when I'm sitting here in front of them and thinking about, okay, should we use a GLP-1 medication in this patient? We have to look at their medical conditions. We have to look at the risk of side effects. Does their medical conditions put them at higher risk? Are they going to get bad symptoms from the side effects, right? For example, if somebody has heart failure and they're on medications to help them, get rid of the excess fluid that they're hanging on to, are they at risk of dehydration if they develop, explosive diarrhea or nausea and vomiting from GLP-1s? I mean, those are all considerations that have to be taken into play. And these patients have to be monitored closely, right? This isn't somebody that I just prescribe medications to and then I'm like, I'll see you in 6 months or 3 months even sometimes. These are patients that we want to make sure that they're doing okay. They know who to call if they're having problems. And once we've had that discussion, once patients understand, I always tell patients, like, these are the alarm signs that we worry about. This is when I want you to reach out to me. Like, don't assume that this is something that's normal. I think sometimes patients think like, hey, these side effects are just what I need to do. It's along for the ride of a GLP-1. And you're like, no, I need you to
Yeah.
reach out to me. So once we have that discussion and ultimately decide to proceed forward, and it's shared decision making, like I always tell patients, like, I'm not here to force you to take this medication. I want you to understand like how it's going to benefit you and what the potential risks are. And I would say the more cardiometabolic comorbidities, and I know that's a term that like a lot of people don't know what that means. And I often think of it as like the intersection of conditions like heart disease, diabetes, and obesity, and others as well, where they share these common pathways of development. So oftentimes, patients could have multiple of these that are occurring at the same time. And we know that there's more and more data to support using these GLP-1 medications to improve multiple health outcomes. It's not just about weight. It's also about if they have fatty liver disease, their blood sugar. We know that blood sugar improves even independent of weight loss when patients are on GLP-1. Same thing for fatty liver disease. Some patients have benefit even if they don't lose a significant amount of weight. So there's other benefits to be had that are not just weight related. And I do want people to understand that. Sometimes I get irritated when it's like, these are weight loss medications or weight loss jabs. And I'm like, that's what they might seem like to the outside world. But in the medical world, we know that these medications have a lot more utility than just managing weight.
So when you think you have a population of patients that, as you just said, is higher risk
Risk, yeah.
than the typical clinic, but you treat a number of patients that we would call average risk. So for the patient that is more like that, for a patient that is, between 35 and say 75 and may have some concerns about prediabetes or metabolic syndrome, talk to me about the risk benefit ratio of a GLP-1 medicine for a patient like that.
Yeah. I would say for patients that I'm going to use the word healthier compared to what I'm comparing it to the other subset of patients that I see. I would say that benefits largely outweigh potential risk, especially when you're receiving that care with a provider or doctor that is comfortable with prescribing the medication and actually helping you troubleshoot through any potential side effects. I always tell patients that, yes, there is a subset of individuals that will not tolerate this medication no matter what we do. But most people, we can get them to a point where they tolerate the medication, even if they had, pretty significant side effects in the beginning. And so when I have that discussion, I really lay it out. Let's say they have prediabetes, or they have a really, prediabetes with strong family history of heart disease, or their triglycerides are elevated, whatever it may be. Like, we talk through how GLP-1 medications can actually improve those conditions. Now, again, it's more nuanced. I can't promise that like they're never going to develop heart disease or they're never going to develop, a certain condition. It's just we're talking about reducing that risk. And I would say in the majority of cases, especially for people that are a bit healthier, they're earlier in life, we do start medications. And I always say the younger you are, the more aggressive we are, because we want to really modify that risk as soon as possible. That we don't want your body to be exposed to high blood sugar for a really long time. We don't want your body to be exposed to like high blood pressure for a really long time, right? We want to really work on getting that under better control so that our hope is that you have better outcomes in the future. Heart disease takes a really long time to develop for most people. And most 20, 30-year-olds are not thinking about that, but I really encourage them to think about that, especially if they're from high-risk ethnicities. Like I'm South Asian. I mean, unfortunately, South Asians are notoriously known for developing diabetes and heart disease at younger ages. I really want them to understand that that's a risk, and not to scare them, but to empower them into, thinking like everything that I'm doing right now is going to reduce my risk. And all we can do is hope for the best. We can't promise that disease will never happen, but we can at least try to reduce our risk or at least stave it off for as long as we can.
You said two things there that I want to follow up on. I think it's important for our viewers to focus on the comment that you made about a younger patient being the kind of patient that you would actually be more aggressive on. And then you also mentioned the increased risk of diabetes and heart disease in people of South Asian origin. Focusing on the first part of that, a lot of younger patients are concerned about the long-term risk of these medicines and are reluctant to take medicines in general. So how do you have a conversation with that kind of a patient if you really think that the cardiometabolic changes that that patient will experience will reduce their risk substantially enough that you think that the medicine is a good idea?
I always ask patients, like, what is the alternative if you decide not to proceed with starting medication right now? And oftentimes that question kind of takes people aback, right? Because they go back and they think, well, I've already tried X, Y, and Z. I've already, done everything I can and feasibly can, right? Sometimes it's not, I always joke and I say, like, if everyone had 5 hours in the day and a personal chef and a trainer and all the best, like, of everything, there are still going to be people out there that struggle because it's not just lifestyle factors that contribute to disease development. There are underlying genetic and biological factors. So I often ask patients, like, if you don't want to start medication right now, what is your plan moving forward? What do you think would help you improve that risk? And that's not to, be facetious or mean or anything. I really want to understand kind of where their thought process is at. And sometimes it takes, time. Like, I have patients that tell me especially if they're younger and they don't kind of see that risk right in front of them, or that disease right in front of them, they may want 6 months to try on their own to improve their blood sugar or improve weight or whatever it may be. And I tell them, like, look, the therapies are always there for you. Let's take 6 months if it's reasonable, and see if that's something that you can work on. And I will say in the majority of cases, people do eventually start medications because I think they recognize that I'm doing everything I can within my income, within my time limits, my work constraints, my family constraints, and it's just not working. And so at that point, I think people are more likely to come around to taking medications. And so I think giving people time and agency to think about their choices is really crucial when you're prescribing these medications, because we don't want to force anyone to do anything that they're not comfortable with within reason. Obviously, if there's some sort of imminent health concern or imminent health threat, that conversation also happens. Like, hey, look, you have advanced disease and we don't really have a lot of time on our side right now to help prevent further complications. And the sad part is I am seeing advanced disease in younger and younger patients. Mm-hmm. And that is super concerning. So if I see that, then I'm like, hey, look, this is the risk benefits of taking medication. Yes, just like taking a medication for diabetes or high blood pressure, in the majority of patients, these are long-term medications, right? There's underlying biology and we can't fix that.
So I want to follow up on that. You said that you're seeing more advanced disease in younger patients.
Yeah.
When you make that comment, you're talking about obesity or metabolic syndrome or heart disease or all three?
I think obesity, fatty liver disease, diabetes, heart disease also in younger patients. Not like it's not like I'm seeing 30-year-olds with a history of heart attack, but people in their 40s, a lot younger than you would think. Depending on the ethnicity, of course, I have seen South Asians, unfortunately, in their 30s develop heart attacks. Maybe they have other risk factors as well, but it's just, it's really devastating when that happens. So it is concerning. I should also say I've seen people in their early 20s with prediabetes and fatty liver disease. I do see that spectrum of patients. I see adults only, I don't see children, but one could argue that somebody who turned 17 to 18,
Yeah.
still is looking to their parents for some guidance with their health. And it's really concerning because I think about like what's ahead for them. What kind of life are they going to live? I want them to live a life where they're thriving, they're healthy, that whatever they're working on as far as lifestyle factors, it feels like it's a part of their values and their core. It shouldn't feel like this chore. It shouldn't feel like a punishment. And it frightens me. I have two young children, and I'm like, what is it going to look like for them when they're, older? Are they, going to be able to stave off the diseases that we're all trying to stave off? I mean, we have in my family, it's incredibly strong family history of like type 2 diabetes. It is everywhere. Both my parents, their siblings, grandparents, several of my cousins, we're all kind of in our 30s, have developed prediabetes, even despite being quote unquote thin or exercising and doing all the things. So it really worries me. And so I think a lot about that.
Yeah. So you've mentioned a couple of times this increase in diabetes risk and the increased risk of heart disease in people of South Asian origin. I want to give you a chance to just say a few more comments about that, because I think it's a thing that not everyone knows.
Yeah.
And so if you could tell me, when you look at a person of South Asian origin, you look at the other risk factors on the patient, how do you put that how do you put that together with the other risk factors for developing diabetes or heart disease? And what are those other risk factors, and what's the actual risk in a patient of South Asian origin?
Yeah, it's significantly higher. I mean, I think that there are certain risk factors, or certain mechanisms, I should say, that can explain some of the risk. For example, South Asians are thought to store more what's called visceral adiposity, or visceral fat. Adiposity is a medical term for body fat. And that's the fat that's actually closest to your internal organs,
Right.
or even inside ectopic fat, of your internal organs. And people often think of like body fat as this, there's not just blobs of fat. Fat is an actually incredibly metabolically active organ. It is making, different hormones, different factors. It's trying to communicate back and forth with like your normal tissue, and it can cause a lot of problems, unfortunately. And so we know patients that store more visceral adiposity are at higher risk of developing heart disease, fatty liver disease, diabetes, amongst other conditions. So I think part of that risk is there. It is also thought that South Asians don't actually have as robust lean mass, or specifically lean muscle mass. I mean, again, there is variation because India, for example, is a very heterogeneous country. There's a lot of variations there. So I don't want to just make some blanket statement, but I do think that the importance of physical activity, especially resistance training, isn't something that many South Asians grew up with thinking about, which whenever I, again, meet a South Asian patient, I'm like, time to exercise. I can't even tell you how important it is for you. Yeah. It's important for everybody, but especially you. I think that is, a factor as well. Lifestyle, I think that many South Asian cultural diets are very refined, carbohydrate heavy. And I'm not saying carbs are problems. Like, there's a lot of nuance there. But it could lead to excess calorie intake. They're not getting, maybe adequate quality protein, for example. And there's other factors at play. The other one I do want to mention is that South Asians are at higher risk of having what's called an elevated lipoprotein A. And that is a specific type of lipid molecule, LDL molecule, that is particularly inflammatory. It's one of those things where you either have an elevated level or you don't, with one caveat, and I'll talk about that. And the way to check for it is a blood test. You check a blood test, and if your level is elevated, it is most likely that there are others in your family that have an elevated level. So it can inform, if you have children, it could inform screening your children or testing your children, telling your parents, maybe they didn't know. I get a red flag, especially if somebody tells me like, hey, my, dad had a heart attack when he was 42 and he didn't smoke. And you're like, okay, that's not normal. And now the lipid guidelines actually recommend checking it as a one-time test in everyone. So if you haven't had one, talk to your doctor, consider getting it checked. But South Asians do happen to have a higher level of that, or higher risk of having a higher level, I should say. And if they have it, what does that mean? It means we need to be even more aggressive with lowering their risk factors for heart disease. Currently, we don't have any medications that are approved specifically to lower lipoprotein A. I think those are they're in development at some point, hopefully. But if you do, we've got to be aggressive. We've got to work on your cholesterol, your blood pressure, your blood sugar, weight, sleep, physical activity, nutrition. I mean, all of it is really important. And so I want people to understand that.
You just said a number of things that I want to follow up on. You mentioned specifically visceral adiposity and lean mass, and you mentioned those as risk factors for metabolic disease. That's something that in my practice we focus a lot on as well. You mentioned the carbohydrate heavy diet in South Asians, and that's the perfect entree to talk about culinary medicine. But I want to save that because that's like a teaser, because I think everybody's really going to be interested in what culinary medicine is and, how you would approach somebody that had a delicious carb heavy diet, And so I want to talk about that. You mentioned LP little a, and I think you did a pretty good job of explaining what it is and why it's important. And then you mentioned sleep and nutrition. Before I get to all of those great topics, I want to finish our discussion about risk and benefit by asking you the question: what are the specific long-term risks associated with GLP-1 medicines? And specifically, is there an increased cancer risk?
Yeah, I'll address the cancer risk because that does come up. So yes, there is a black box warning for this medication class for patients that have had a history or a family history of a specific type of thyroid cancer, which is called medullary thyroid cancer. That is exceedingly rare, especially if it's a part of this other endocrine system or endocrine syndrome called MEN2. I have yet to meet a patient with either MEN2 or medullary thyroid cancer. That is not to say that those patients do not exist. It's just I do not encounter them in my practice given the rarity of both of those conditions. I mean, if you asked an endocrinologist who sees patients for thyroid cancer, they would probably give you a different answer potentially, but I think in general everyone would agree that it is rare. Now, I often get asked, okay, do GLP-1s increase risk of other types of cancers? And we actually are getting more and more data to understand that, well, managing obesity, and perhaps it's with some sort of independent mechanism of GLP-1, shows decreases in risk of developing certain cancers. I'm not saying every cancer. I'm not saying that now we should all go take GLP-1s for cancer prevention, but there seems to be potential benefit. Now, again, that has to be studied, and I think those studies, are worth doing. But in most cases, like I said, always benefits outweigh risk. Now, as far as pancreatitis and gallbladder disease, so we know, for example, I'm going to focus on the gallbladder disease for a second. We know that when individuals experience rapid weight loss, whether it be from bariatric surgery, and some of these GLP-1 medications in some patients really can result in significant weight loss, they're at higher risk of developing gallstones. Patients with obesity are at higher risk of developing gallstones. So I think it is worth exploring that further when you're thinking about, are you going to start a GLP-1 medication in a patient that's been having pain over their gallbladder area when they eat? Probably best to address that before starting a GLP-1 medication. I always counsel patients if they've ever, if they have gallstones, like, hey, this could become a problem. One of the things to consider is if you've been having pain, obviously, let's have you see somebody and think about like whether or not you need to have your gallbladder taken out. Some bariatric surgeons will actually take out the gallbladder preemptively when they do a gastric sleeve procedure because they know that these patients are at higher risk of developing it. We also think that there is some direct mechanism potentially on the gallbladder itself from a GLP-1 medication. But it is a conversation that I have, and I always look kind of back at imaging, and I'm like, hey, did this patient have gallstones? Did they know they have gallstones? There's sometimes we can give medications to help reduce their risk of developing gallstones. The pancreatitis one is interesting. I think that there is been a lot of like talk about pancreatitis risk with GLP-1 medications. I should say in my I say former life, but when I first started my career after training, I was a hospitalist and I worked on the inpatient side and I saw a lot of pancreatitis. And the most common causes are alcohol and gallstones. So again, counseling patients on that risk of not only could you develop, stones lodging in your gallbladder, causing infection there, if the stone was to lodge further down, you could develop pancreatitis, but it's not to say that the GLP-1 caused the pancreatitis. When you actually look at multiple studies and you do like a meta-analysis, we're not really seeing like that significantly increased risk of developing pancreatitis on GLP-1s. And that's for somebody without a history of pancreatitis. If we're talking about somebody with a history of pancreatitis, again, it's worth asking, of course, like, why did you get pancreatitis? Do we know? Was it a medication? Was it gallstones? Was it alcohol? Was it some other cause? And again, I have yet to meet somebody that's had GLP-1 induced pancreatitis. If GLP-1s were truly the cause of their pancreatitis, by all means, we don't want to use a GLP-1 in them. But in the majority of cases, there's some other cause. And depending on how severe their pancreatitis has been, or if they've recovered from it, I think it's reasonable to have that risk benefits discussion and think about, okay, this person has diabetes, they have obesity, they have sleep apnea, they have, fatty liver disease. What's going to happen to them if we leave this untreated, right? Versus like a potential risk of developing another episode of pancreatitis. So it's not always as clear cut as I made it sound, but like like I said, in most cases, we do end up using medications with close follow-up and counseling patients. Like, if you develop any of these symptoms, I need you to stop the medication, let me know. And especially if they had symptoms of pancreatitis. Have I seen gallstone pancreatitis? I've seen it a number of times. That is a real risk. If patients have gallstones and they're on a GLP-1 and they develop more gallstones because of the weight loss, I mean, that could increase their risk of developing pancreatitis if that stone were to get lodged in the wrong place. So, it is important to have those conversations. And I think I go back to, appropriate medical care, right? We don't want patients just getting some GLP-1 off the internet and they've never been counseled on what to look out for or who to call. That really does concern me.
Excellent. Okay, let's get back to that question about visceral adiposity and lean mass, because when you were talking about visceral adiposity and the increased risk that people of South Asian origin have of developing visceral adiposity, you made, I think, a really important comment about the endocrine effects of fat, of body fat. And I think that is a topic that not a lot of people really fully understand.
Yeah.
And then you also mentioned lean mass. And when we were talking before we started the interview, you talked about muscle as a metabolic organ.
Yeah.
So my questions are, do you measure visceral adiposity and lean mass when you're assessing a patient? And do you follow it over time? And if so, how do you do that? And then if you could explain those really excellent comments about the endocrine effects of visceral adiposity and lean mass.
Yeah. So I do follow body composition in patients. So whenever I tell patients, it's not just about losing weight, right? Everyone's kind of focused on weight. It's often the outcome in studies. It's about improving your body composition. We want to improve your body fat percentage and retain, if not gain, as much lean muscle mass as possible. Now, there are scary numbers out there in the clinical trials where people are 40% of lean mass loss. And it's I really want people to understand that lean mass is not the same thing as muscle. About 50% 50% of lean mass is muscle. So whenever people report lean mass loss, people often just think it's like somebody lost 40% of their muscle, and that's just not true. So we know that when there is fat that surrounds our muscle, that's the medical term is myosteatosis. That is particularly, again, inflammatory. It's the fat that's closest to our muscle, and it's thought to affect muscle function. So let's say even if somebody has really robust lean muscle mass, they may not have good function. They may not have good power, endurance, and strength, partially because maybe they haven't conditioned themselves in that way if they're not exercising, and partially because there could be some component of that fat that is creating that bad environment for your muscle. And so even if somebody loses lean mass, or lean muscle mass, I should say, that doesn't mean that they're just going to get frail and weaker automatically. Now, again, I'll go back to what I was saying earlier before we started talking, that in my patient population that's already sicker, has multiple chronic conditions, I do worry that, we could make them more frail and reduce their function and significantly reduce their skeletal muscle mass if we're not careful with dosing and how fast they're losing weight and all of that. So muscle is a metabolic organ, just like fat. There's a lot of different factors that are being made there, and they're communicating with that fat as well. And so just like when fat sits closest to our internal organs in our abdomen and our heart, it causes the same problems in our muscle, or similar problems, not the same. I mean, I'm oversimplifying here, but there's a problem there, right? And so when people lose weight, unfortunately, we can't target where they lose weight. I wish it was all in the places that people want, but we do bank on them losing some visceral adiposity in addition to what was called subcutaneous adiposity, which is like the fat that's in your thighs, hips, and buttocks. It's more quote unquote superficial. It's less inflammatory compared to the fat that sits closest to your internal organs. So they're going to lose body fat. They're going to lose visceral fat. And we track that with the body composition. I have a body composition machine. I have a bioelectrical impedance machine in my clinic. The gold standard is a DEXA scan. If you've had a DEXA scan for osteoporosis, you're probably familiar with that. Unfortunately, a lot of health systems don't offer DEXA scans for body composition themselves, but thankfully, at least in the Bay Area, there are some more affordable options to actually go out and get a DEXA scan done with another company, and then I ask patients to bring that result back to me, and we do track it. I think it's really empowering for patients to see sometimes because the scale doesn't tell you everything. For example, I recall one time there was a patient that had lost 20 pounds after being on a medication for over a year, and it was very disheartening to them because they thought in their head, like, in their mind, and I understand why, that it was only 20 pounds. But when we tracked their body composition, it was mostly body fat. And they had gained muscle because they were very active. It was just really cool to be able to tell them that. Like, look, the number on the scale is not telling you the whole picture for yourself. And I do think body composition is empowering for patients. It's also a very good clinical tool. I know it's not widely available. I think in the clinical setting, if we can at least have a bioelectrical impedance, preferably a DEXA scan that we track every 3 months, 6 months. I tell patients we're not doing this monthly. I know you want to, but let's not do that for a lot of reasons. I think it could be really beneficial for patients. So we do track it, and it's fun. It's fun seeing the changes.
I agree with you. I also track it in my office, and I also think it's a rewarding part of taking care of patients for exactly the reason that you mentioned, which is they could not be getting to their goal weight, but they could be improving their muscle mass and reducing body fat percent. And in terms of their overall health, that's actually better for them anyway.
Better for them, yeah.
Yeah. Great. So the next question I have for you is about cardiovascular benefits. So how should the cardiovascular benefits of these medicines change the way that we think about the GLP-1s?
Yeah, the cardiovascular benefits are pretty cool. We know that there's data to support using, for example, semaglutide, the name brand is Wegovy, in patients that have had a history of cardiovascular disease and they have obesity. We have really good data for patients with diabetes. We know that with patients with diabetes that GLP-1 medications reduce their risk of developing heart disease, and kidney disease as well. I think we're going to get more and more data for patients without diabetes that will also hopefully show some benefit. We'll see. But we know that patients that have had a stroke or heart attack or history of peripheral artery disease that's symptomatic, that if they take, I'm using the name brand, but again, I have no affiliations with any pharmaceutical company. I just want to throw that out there. Wegovy or semaglutide will potentially reduce their risk. We also have data support that in patients with specific types of heart failure, what's called heart failure with preserved ejection fraction, that medications like semaglutide and tirzepatide can actually improve symptoms. And specifically with tirzepatide, they saw a reduction in hospitalizations and I believe mortality. Don't quote me on that. Just we got to check and make sure, but it's been a little while since I read that study. And so we are starting to see more and more benefit from a cardiovascular standpoint. I mean, anecdotally, I will say this is, again, what I've seen in clinical practice, that patients' heart failure symptoms have improved, even if they don't have the HFpEF, they have what's called HFrEF, which is reduction in ejection fraction, meaning that their heart muscle has a tough time with contracting. I've seen improvements. Sometimes we have to go down on their diuretic dosing in conjunction with their cardiologist, which is pretty cool. So I'm hoping that we get more and more data to really think about using these medication classes in patients with heart disease of different kinds.
Excellent. All right. What role do GLP-1 and related therapies have in the treatment and prevention of fatty liver disease? And if you could explain fatty liver disease to the listeners, what it is and why people who have metabolic diseases or obesity are at risk.
Yeah. So the way to think about fatty liver disease and the metabolic, or the liver manifestation of metabolic syndrome, because again, a lot of these medical conditions go together, like diabetes, fatty liver disease. I mean, patients often there's higher risk when you have both of those. So fatty liver disease is when your liver stores more fat than it can handle, in a nutshell, for patients to understand. Typically in a normal liver, less than 5% of your liver cells have fat. But as time goes on, for these patients, they store more and more fat. It's almost like this is very simplistic, but spilling over from other fat depots. So if you're carrying more in your abdomen, it's got to go somewhere and it starts to go in and around different organs. And remember, that fat is really inflammatory. So if it's in your liver, it's like talking to your normal liver and starting to cause problems. It starts causing inflammation for some people, and in some patients, they actually develop scar tissue and that end-stage liver failure. Now, this is very simplistic the way I'm saying it. It's a little bit more complicated. I'm not trying to imply that everybody with quote-unquote fatty liver disease gets end-stage liver failure. It is a subset. But when we see patients with fatty liver disease, I don't discount it. I don't just say it's a little bit of fat in your liver. I'm saying, hey, this is telling us that there's something wrong. And we really want to start working on trying to improve your risk factors for, developing progression to end-stage liver failure or diabetes if you have it, or heart disease or whatever. And so I use it as a catalyst to have that discussion. And when I was talking about younger patients having, medical conditions that you often wouldn't expect, I'm seeing fatty liver disease in young patients, in their late teens, and they probably started developing it when they were, kids or adolescents. And so it's just very concerning. But again, I tell them, look, there's so much we can do with GLP-1 medications, with weight management, with better diabetes control, exercise to really try to improve that. The GLP-1 medications are very effective at improving, especially steatosis, or that fat in the liver, and inflammation in a subset of patients, and even fibrosis or scar tissue, depending on how severe the disease is. Now, we don't have that data for patients with end-stage liver failure. The thought is that perhaps it could help stabilize symptoms or stabilize the degree of scar tissue, but TBD for that one.
Okay, great. I'm going to ask you about other medicines other than GLP-1s that can be used for weight loss. And this is going to be educational for me because I don't use them that much. But do older medicines, such as the one with the trade name Qsymia or Contrave, do those have an important role in obesity treatment? Do you use them? Are there other medicines that patients should be thinking about or considering?
Yeah, those medications are still used. I would say that they're probably used a little less often, but they're still used. Partially in my patient population, it's because the patients can't be on those medications for a number of reasons. Like either they have liver failure or kidney failure, and some of those medications are contraindicated. But they are medications I use in synergy, especially with GLP-1s. So how much weight somebody loses on a GLP-1, I always told them it's going to be very variable from individual to individual. You have clinical trials, and then when you actually look at the spread of participants and like how much everybody lost, I mean, it's people on both sides, or even individuals that gained weight on a GLP-1. And so let's say patients are losing and they're at a weight loss plateau. They haven't experienced any further weight loss in a few months, and we still have some work to do for whatever reason. I may add something on top of it to help synergize or work through a different pathway to help with weight management. It could help. Your body's really good at fighting back against the GLP-1 eventually. Maybe you start feeling a little hungrier, or the cravings are starting to come back. And you're like, I find myself snacking a little bit more in the afternoon, or I find myself gravitating towards the ice cream at night. Could we use one of these medications to help calm that down? And so I do use them. Sometimes I use them by themselves, like Qsymia, for example. It's generic now, and so it was definitely more affordable, yeah, than
Go ahead
GLP-1.
and say the generic name for it.
Oh yeah,
Just so,
phentermine topamax, or topimerate, excuse me, phentermine topimerate. I use those components broken up. Both of those are individual medications that I could use. It does allow us to titrate to the individual and to their tolerance. I don't use Contrave as much, bupropion and naltrexone.
right.
I do use the individual components, probably bupropion more than naltrexone. And there is a significant side effect of nausea with Contrave is from the naltrexone portion of it. So sometimes using the combo tablet, people may not be able to tolerate it. But, it's a tool out there. It could be beneficial to certain patients. There are other off-label medications which I use less often, but I know about them. Like zonisamide is what we call it topimerate light. And then there's also other kind of similar medications as phentermine that could be considered. This is kind of getting into the weeds and nuance. I don't, like I said, use those as often, but I do use those. I use the full breadth of medications to help patients. We understand that there is, just like with the triple agonist, for example, like retatrutide, when you're working on different receptors and different pathways, potentially, there seems to be some synergy in weight loss. And so this is the thought as to why combination treatment could be beneficial for a patient.
So would you say that the situation that you just described, where a patient has plateaued on a GLP-1 medicine, might be a situation to consider one of those older medicines like Qsymia or Contrave, and that the primary thing that you're trying to do in that circumstance is reduce food noise or cravings. Is that accurate, or is that an oversimplification?
No, I think after you've ruled out like reversible causes of a plateau. So, for example, did that person's physical activity change? Is their sleep different? Did they start, did they go from a job that was really active to like really sedentary? Like, there's all these things to consider and really think about when we're, did they introduce more alcohol into their diet? So all these things we want to kind of talk about, think about as to potentially contributing to a plateau or even modest weight regain. And if after all of that, you're like, there's nothing that we can pinpoint, then I think it is reasonable to add, medications on top, depending on the individual, what their history is, to help quiet down some of that food noise that's returning. Because again, that's the biology at play. That's like, I want you to eat something very tasty. Some people have a lot of food noise, and there's people out there that are like, I eat to live, and then there's people out there that live to eat. And I'm definitely a live to eat person, so can empathize with my patients and the food noise. And I think those patients would really benefit from additional therapy potentially.
Okay, let's talk about the new and upcoming exciting new medicines, retatrutide, any of the other medicines that you want to mention that are potentially in the pipeline, or specifically with retatrutide, because there's a lot of interest in it.
Yeah.
If you know anything about the existing trials related to that, the additional weight loss somebody might experience with that medicine, and the FDA process for getting it approved so it's generally available.
Yeah, so I know that the pharmaceutical company that is developing retatrutide, I think they delayed their FDA approval request until like 2027. I'm not saying it the right way, but it's not. I don't think it's going to get approved later on this year, at least based on what I saw out there as a news release. But it is an interesting medication. When semaglutide was approved as Wegovy, it was like, wow, there's on average 15% total body weight loss. And then came tirzepatide, and it was like, wow, there's average of 20% of total body weight loss. And now we're like, wow, it's like we're getting into the bariatric surgery level of weight loss for some patients. And
So is it
I think
closer to
it's,
40%?
yeah,
What's the weight loss?
well, yeah, so I think more patients achieved at least 20% of their total body weight loss. And there were some that went up to 30%. And it was not an insignificant number or more. And at least from the initial trials, they did not see a weight loss plateau when they ended the study, which is interesting. Now, we do know that the most robust weight loss for a lot of these medications occurs like within the earlier study periods, like within the first 6 months, and things tend to really slow down after that. But there was no plateau here, which was interesting, at least in that particular study. Not to say that they'll never plateau. And again, there's inter-individual variability. But it is exciting to see this. It is also, in my mind, like more reason to think about appropriate use of these medications by somebody who feels comfortable managing side effects and symptoms and making sure body composition is taken into account. Because again, if you're using a medication that somebody could lose 30%, 40% of their body weight, 35, whatever it may be, that significant number, then we need to ask ourselves, is this the healthiest thing for them? Are they going to experience healthy weight loss? I think like many medication classes, there's probably going to be like a tiered system as far as like, who do we use this medication in? It's not like, I think I'm going to give everybody retatrutide, when it gets approved. It's like, how severe of obesity do they have? What are their comorbidities? Could they benefit from this significant weight loss? That's the kind of conversations that we're going to have. What's interesting about glucagon is that it's thought to also increase energy expenditure. So a lot of the medication class that we currently use are thought to reduce how much quote unquote food or energy people are taking in, right? We don't have one necessarily that's like, hey, this is going to make you burn more calories. And it's thought that glucagon could potentially help with that. So again, very interesting to see all of these therapeutics in development. I can't even keep track of the number of therapeutics in development. Every time I look at some paper that's published a chart, oh my gosh, it's like exploding. But suffice it to say that we think that working through different mechanisms versus just like focusing on GLP-1 by itself seems to have a synergistic or an additive effect, I should say. And it'll be interesting to see.
Excellent. Okay, so I want to give you a chance to talk about culinary medicine. You mentioned the high carb diet and people of South Asian origin, and as a person who loves Indian food and the carbs associated with it, the rice and the bread and all that stuff. I want to give you a chance to explain what culinary medicine is, how you use it in your patients, and give us a little background on it.
Yeah, so I think of culinary medicine as the intersection of culinary literacy, health, and nutrition. So it's not enough for us to say, like, hey, you should eat healthy, make a salad, make your own salad dressing. What if that person doesn't know how to do that? um, I mean, salad may be okay, depending on that person's definition of salad. For me, not the best example, but um, making their pasta healthier or using different kinds of ingredients. Like if they don't know how to do that in their own kitchen, then we're just really not servicing, we're doing a disservice to them. And I really do think culinary literacy is crucial to improving long-term nutrition for patients. But a lot of this exists in silos, right? Chefs are in the culinary world, and doctors and dietitians are, and again, there are many dietitians out there that definitely talk to their patients about culinary skills, but we really want to make this like a widespread movement. Like this is just integrated into clinical care. Like patients not only learn how to put healthier meals together, but they can translate that into a skill, like in the kitchen. There are medical schools that are teaching their medical students and health professional students culinary literacy. They get to go and be in the teaching kitchen. I was like, I wish I had gone to a medical school like that, alongside dietitians and chefs and even patients to really translate that knowledge into practical skill and action, which is so empowering. I mean, it truly changed my life when I learned how to cook. Like, I know it sounds very simplistic in that way, but I didn't grow up, I had no interest in learning how to make food in the kitchen. It wasn't until I was done with my training that I was like, okay, I probably should learn some things. And learning not just how to cook, but learning how to make nutritious meals that you enjoy. Vegetables don't have to taste like crap, right? You don't have to eat them raw. There's so many different ways to eat them in ways that you enjoy, even for people that are quote unquote picky eaters. I often say, like, if you don't like broccoli, like, how did you eat it? Is it because you try to eat it raw, dipped in ranch to cover up the taste? Or did you roast it? Did you put it as a part of a really hearty salad that has all these other really fun ingredients? And this doesn't have to be complicated. This doesn't have to be expensive. Like you don't need to go cross town to some specialty store to get this one ingredient that you'll only use once. Like it's really meant to be practical and give people a blueprint of how to put meals together. And I think with AI, it's been really fun. Like I have been experimenting with recipes with ChatGPT. This morning I made, I'll just show you, it doesn't look that good, but it is an almond flour cottage cheese muffin that my with some chocolate chips that I fed to my toddler. And I also made it so that it's, something that I could eat too. So there's just so many different ways to incorporate health promoting ingredients, health promoting foods, but it takes time. It takes time to practice that skill. It takes time to get comfortable in the kitchen. I joke and I say a chef's knife is like the best health intervention because you get to learn how to cut up veggies really quickly so that you're not spending hours and hours in the kitchen. It's really fun. Like when we talk to patients about like how to put things together. I mean, we're working on getting a mobile teaching kitchen, eventually, hopefully be able to offer like kind of more structured cooking classes. It's really empowering and truly life-changing.
Excellent. Nisha, thank you. This has been an absolutely fascinating discussion. I have learned a ton. I think the central message is that the medicines that are used for weight loss are not simply tools for losing weight. They are powerful cardiometabolic therapies that can reduce disease risk, but they still require careful patient selection, monitoring, nutrition, exercise, and a long-term plan. The science is moving rapidly, access is beginning to improve, and even more effective therapies may soon be available. But the prescription is only one part of the good treatment.
Yeah.
If for anyone considering a GLP-1 medicine who wants a more complete assessment of their metabolic health, LifeLab offers a $249 metabolic weight loss assessment. We measure resting metabolism, review cardiovascular and metabolic risk, and help patients decide whether medication is appropriate and how to use it safely if it is. Nisha, thank you so much for joining me on LifeLab Conversations. I'm quite sure you're going to go viral. This is an absolutely amazing discussion.